Welcome. We're here tonight to provide another episode in the series called Westminster Residents Present. It'll take about 45 to 50 minutes, not more than that. The movie will come on at 8, so you can relax. These programs can never be a substitute for the normal times when we could all get together for Monday evenings in Harris Bell Hall. But these sessions, we hope, will help you to get to know your neighbors better and to know something about their particular interests. Our programs will vary in format. You may have seen a couple of them. Tonight, we're going to try a format of about 25-minute presentation with questions by a couple of panelists who will ask questions on behalf of our total audience who can't be here with us. Now, you'll note that we're not wearing masks. We're doing this at exaggerated distances in the filming, and our esteemed film director, Vicki Yanis, is wearing a mask as she moves among us during the recording. Tonight, I'm your host, Ken Ashworth. We're still finding our way with technology and timing. So if there's some glitches and some awkward moments, we hope that you'll join us in looking upon those as carefully crafted spontaneity. What we lack in polish, we are going to try to make up in boldness in doing these sessions among our neighbors. Our panelists, first our topic tonight is sleep. And our resident presenter is Dr. William Sluice. Our two panelists are Jerry Smith and Kathy Kelly. Jerry has been in Westminster here for 3 years now. She's a lifelong Texan. She's a homemaker and active community volunteer. She personally had the opportunity to know Harris Bell and his wife Lola when she came to Austin as a young woman. And of course, being a volunteer, that's why she's here with us tonight. Kathy Kelly is known to most of you. Many of you have probably been welcomed by her with her work on the Welcoming Committee. She's also known for her fast-paced walking tours around Austin, and she's another avid volunteer. She's contributed much to the Westminster community. She has BS from Suffolk University in Boston, and with a name like Kelly, nothing could be more fitting than to find that she's from Ireland originally. A brief word about our speaker. Bill Sluice is a native of Austin and San Antonio. He's a graduate of UT and the oldest medical school in Texas, the UT Medical Branch in Galveston. He's also a graduate of New Orleans Psychoanalytical Institute. He's practiced and taught psychiatry in Houston and Austin for over 40 years. He enjoys sailing, flying, photography, the history of photography, and he's developing a new interest, art history. So with that, let's turn to Bill and have you start the program.
Thank you very much, Ken, for that introduction. If you wondered whether I'm still practicing, I'm not. I retired 20 years ago, actually 21 years ago as of middle of June. I enjoyed practice to the last, but I had other things I wanted to do. We'll try to give a run through on sleep tonight. It's a big subject, so it will be a primer and not much more. When you think about it, we spend about a third of our life sleeping. So if you're 90 years old, you spend about 30 years sleeping. So it's an important subject on that score, if no other. And interestingly, only in the last 60 years or so have we started to learn something about the structure of sleep and the physiology of sleep, and have been able to characterize specific sleep disorders. There were earlier writings on dreams, of course, mostly speculative from prophetic dreams, various things. The first systematic study was Sigmund Freud's major book, 1900 book on dreams, but we won't get into the psychoanalytic aspect of dreams tonight, or this afternoon. Two fundamental discoveries are basic to our understanding of sleep. First, the circadian rhythm. This is an internal process that regulates the sleep-wake cycle and other functions. Repeats about a 24-hour interval. That's the term circa around, dia from the Latin word for day, around a day, also referred to as the body clock. It can refer to any biological process that displays an endogenous, that is built-in, oscillation of about 24 hours. Also, it's not to be confused with the periodic cycle of the insect cicada. I've had several students that were conflating the two, which has a life cycle of either 13 or 17 years. This rather confusing diagram is an attempt to illustrate the circadian rhythm with noon at the top and midnight at the bottom. So the right half is daytime, the top half is daytime, the lower half is night, with various physiologic peaks and valleys. We won't spend a lot of time on that. Interestingly, in 2017, the Nobel in Physiology or Medicine was awarded to these three gentlemen for discovering of the molecular mechanisms controlling circadian rhythm in fruit flies. Fruit flies have been a fruitful source of research from lots of things, including circadian rhythm. This gentleman, William DeMint, who just left us, died in June of this year, wonderful fella. He established the specialty of sleep medicine. He discovered pretty much single-handedly the sleep cycle, the phases of sleep and dreaming. He was a real pioneer. He was MD, PhD, headed research from the beginning, had a long tenure as a professor of psychiatry at Stanford. He also had a very popular general course on sleep that was open to all undergraduates and was always chock full with a waiting list. His legacy is remarkable. I'm really surprised that he didn't win a Nobel Prize, and now that he's dead, he's not eligible, I believe. Back to the circadian rhythm for a moment, I should say. The circadian rhythm is reset to the 24 hours by several exogenous stimuli, notably light, and we'll say more about that later. I mentioned the sleep cycle. Whoops. This is a rather simple diagram. I'm looking at the next slide. This is a simple diagram of the sleep cycle that DeMint discovered or charted out. It's a nice, this shows an 8-hour night with 5 cycles, starting awake, passing into stage 1, then 2, 3, 4, and back again with a REM sleep cycle, and we'll say more about that in a moment. The red areas at the end of each cycle. That's the first cut. We'll say more as we look at it in more detail. This is a diagram of the first cycle of a night's sleep. The top squiggles are EEGs. The discovery and charting of the sleep cycles were primarily from EEG, which was brought into general use in the 30s and used a lot after World War II. And each cycle has a characteristic sleep pattern. With a clinical study for seizures and whatnot, there are 12 leads of EEGs for sleep. They're just sampling one to show the overall pattern, the overall rhythm. In a waking state, you have high frequency low amplitude waves called alpha or beta waves, and we need to go into the difference between those. When you go to sleep, you go through a brief period, and then into stage 1 sleep, where the waves start slowing, although looking at them, they look about the same, but if you measure them, they're a little slower. These are called theta waves. As you go into deeper sleep, stages 2, 3, and 4, you get increasing or decreasing amplitude of waves and frequency. And in stage 2, you get these curious little formations called sleep spindles. It's characteristic of that stage. Stages 3 and 4 are deep sleep. As the waves get longer, higher, as you can see, stage 3 is kind of a mixture of the shorter and the longer waves. Stage 4, delta waves, they're called long, slow waves. Some schemes condense stages 3 and 4, and it's arbitrary, but you can separate them. As I said, I've already mentioned this, stage 3 and 4. After all these periods are called non-REM sleep. After they're done, you go briefly through the earlier stages and then into a period of so-called REM sleep. Why is it called that? Because REM is an acronym for rapid eye movement. And this is the stage of sleep in which you dream and your eyes move in a way that's recorded on an EEG. It was first regarded as an artifact and sort of disregarded. In fact, it's interesting, Dement's supervisor, one of his colleagues in grad school, he did an MD and a couple of years later, PhD. The REM cycle, the rapid eye movements, coordinated with sleep, and coordinated with dreaming, were first noticed by another grad student, a fellow named Aswalinsky. And he pointed them out to Dement, and they talked about their supervisor, who was Clements, I believe. Anyway, the supervisor thought that was interesting, but kind of didn't really mean anything. So did Aswalinsky, but Dement took it and ran with it, and just did what I outlined earlier. These can appear in the EEG, and of course now I'm studying sleep. We have leads that particularly measure the potentials from the tiny extraocular muscles. These are the little bitty muscles that move your eye to and fro. Okay, back to the whole sleep cycle. Stage 1 lasts 5 to 10 minutes. Physiological changes, heart and breathing slow, metabolic activity slows roughly half. Stage 2, 5 to 15 minutes, body temperature drops, respiratory and heart rate slow down, brain waves lengthen, intermittent spindles occur. 3 and 4, called slow wave sleep, again, the pattern I described. During this time, heart rate and respiration slow very dramatically. Stage 4 lasts from 20 to 40 minutes in the first cycle, makes up 10 to 15% of sleep. The arousal threshold, that is how easy or hard it is to awake, is the highest for all non-REM stages in stage 4, very deep sleep. In the subsequent cycles, let's talk about REM sleep. In the final period of REM sleep in the cycle, brain waves are similar to waking. Brain metabolism increases, skeletal muscles relax, sometimes called sleep paralysis. In the earlier stages, there can be some random motion. The extraocular muscles are active, and if you awake someone during REM sleep, they will invariably report dreaming. So if sleep perchance to dream is sleep, you will dream, and in the REM period, whether you remember it or not. And most spontaneous awakenings occur at the end of a REM period. If you don't set an alarm and just let yourself wake up, you will probably wake up at the end of a REM period. Interestingly, the most likely time to wake up in the middle of the night, unless it's a bathroom call or something, or sometimes even then, is about halfway through, when you're almost through with your deep sleep. The later cycles are much less deep. You may not even go into stage 4. This is probably too complicated to go into. This just charts various physiological changes I've mentioned here, the heart rate, respiration. An interesting side effect, or not side effect, but incidental observation. During REM sleep, there is, in younger people anyhow, genital congestion. For men, an erection. For women, if you measure it carefully, engorgement of the genital structures. And this too is pretty invariable. Okay, how much sleep do we need? That's a frequent question. Most adults require about 7 to 8 hours. Infants sleep about 16 hours, and the amount of sleep decreases with age. Adolescents need about 8 to 10 hours, and often don't get that the way our school schedules are. Older adults need about the same amount of sleep as younger, but there's a kicker, there's a joker in the deck. Our sleep efficiency declines with age, meaning we have more periods of wakefulness, may take longer to get to sleep, may wake up, stay awake more. So we often need to spend more time in bed to get the same amount of sleep. So if it seems like you're sleeping more, you're probably sleeping about the same. It's nothing to worry about, it's perfectly normal, it's just part of aging along with a lot of other things we know about. Sadly, about 40% of Americans don't get enough sleep, and that's of all ages. And contrary to the way this chart looks, they're not all in the western half of the country, but that's a joke. What happens if you don't get enough sleep? It can cause daytime drowsiness, obviously, but also functional impairments all through the day. Degrades our judgment, our reaction time, and other mental and physical functions. And it's cumulative. If you get a short night and another short night, then you're worse and worse. This is not a trivial matter. Chronic sleep deprivation is a risk factor for high blood pressure, stroke, and diabetes, and these are only the most common things you can mention. As well, there are accidents at home and work, of course. Drivers who fall asleep at the wheel are estimated to cause about 55,000 traffic accidents every year in the U.S. alone, and about 1,500 deaths. That's obviously an estimate, but it's very significant. So how about sleep disorders aside from just not getting enough sleep? We'll mention a few common primary sleep disorders. Insomnia is a general term for any difficulty going to sleep or maintaining sleep that don't have a specific cause identified for, and it's used until or unless a more specific sleep disorder is identified. Sleep apnea is a big one, particularly obstructive sleep apnea. Apnea means no breath, cessation of breathing, and it can be either peripheral, obstructive of the airway, central from your brain stops sending a signal, or mixed. We all have some pauses in the sleep that, if they're exaggerated, could be central apnea. Problems with that are pretty unusual. Unfortunately, obstructive sleep apnea is not unusual, and I'll say a good bit more about that later. Periodic limb movement disorder, sometimes called myoclonus or myoclonic jerks, occurs during sleep and is a sudden jerk of muscles. It's benign, it can be trivial or bothersome. It's a benign condition, but can be unpleasant. If it occurs when you're going to sleep, we call those sleep starts. And most most of us have had them occasionally. Sundown syndrome is a curious name. It's a term for a problem of wakefulness and attention late in the day. Most of the people who have it are people with some dementia. Almost half the people with dementia will experience it at some time. Become confused, disoriented, sometimes agitated. I misspoke. It actually occurs in 2/3 of patients with dementia. It may be mild or severe. It can be a real management problem if it's severe. It may be worsened by extrinsic factors like reduced sensory input if lighting is dim. It has some of the same aggravating factors that delirium does. Somebody who's real sick and goes into delirium. Narcolepsy is not a common disorder, but we hear about it a lot, so I'll mention it. It's characterized by episodes of irresistible daytime sleepiness. Episodes of sudden muscle weakness may occur either separately or together. The episodes of sudden muscle weakness, interestingly, are sometimes precipitated by a loud noise or something, a startle reaction, basically. Restless leg syndrome, you've probably heard of. It's not considered a true sleep disorder, but it may be involved in differential diagnosis, deciding what the problem is, and it can occur along with a sleep disorder, of course. It's characterized by restless or creeping feelings in the legs and a strong urge to move them. And this can happen when you're trying to go to sleep or other times. It's relieved by moving the legs, walking, or kicking. And it might be caused by abnormalities in neurotransmitters. It's not real well understood at this point. And then, of course, there are other rare sleep problems, but there are also, Mr. Slide, okay. There are lots of secondary reasons to have trouble sleeping as well, of course. Any disorder with chronic pain, cancer, of course, arthritis. Some pains are characteristic, like night pain for people with osteoarthritis of the knee and other disorders. Cardiovascular disorders can interfere with sleep. Very commonly, someone who may have shortness of breath, dyspnea, if they're lying flat and have to sit up. That's the fancy term for that's orthopnea, positional dyspnea. Also, some people with congestive failure will have sudden bouts of dyspnea called paroxysmal dyspnea, and especially at night. Any skin condition causing itching, of course, can interfere with sleep. Depression is a big one. A number of psychiatric illnesses can be associated with insomnia. Depressed patients may have any kind of sleep disturbance, but most characteristically what we call a terminal sleep disturbance, which means waking up early in the morning without being able to go back to sleep. But they can also have mixed sleep disturbance. Anxiety disorders, post-traumatic stress disorders are frequently associated with insomnia. PTSD has a well-known association with nightmares, as most everybody knows. Excuse me. Patients with dementia are prone to various sleep problems. The sundown syndrome I mentioned. And of course, people with major mental disorders can have almost any kind of sleep disorder. Some medications can have side effects that interfere with sleep or with wakefulness. Many cause daytime drowsiness or confusion. Some can cause difficulty falling asleep. Read the drug information for any medicine you're taking. But many medicine, I have to say that this drowsiness is a side effect. It may not be a serious problem, or it may be something that you get accustomed to and only have initially. Caffeine, of course, increases wakefulness, can interfere with sleep time, and its effects can last longer as we age, as much as 8 to 14 hours. So, if you're like me, when I was younger, I would drink coffee in the afternoon, have a cup of coffee after dinner, and sleep like a log. Now, I can't drink coffee after about 3 o'clock in the afternoon. Curiously, some people, even getting older, don't have that at all. They can still have caffeinated coffee after dinner and sleep just fine. So that's probably a built-in thing. Remember that caffeine is present, of course, not just in coffee and tea, but in many soft drinks. Nicotine, we don't smoke around here, but nicotine is also a stimulant, and smokers are prone to have sleep problems. How are we doing on time, Ken? Okay. So, what if you don't suspect that you have a named sleep disorder, but you still don't get a good night's sleep? Well, we refer you to a list quaintly called sleep hygiene. Hygiene seems kind of an old-fashioned term. Basically, it's pointers for getting a good night's sleep. And if you don't do all these things and you still sleep fine, don't worry about it. But if you're having trouble sleep, this is a good checklist. And if you're really having trouble sleep, it's well to check down the list. I'll go over them fairly quickly. Probably the most important single one is, I should have mentioned one more thing under drugs. Alcohol, although a toddy may help you go to sleep, alcohol does not do good things to your sleep architecture, and it will promote wakefulness during the night. So beware. Other than avoiding caffeine and alcohol, too much alcohol, getting up at the same time in the morning is the most important single thing you can do to establish a good circadian rhythm and a good sleep pattern. Even if it's Sunday, and even if you stayed up a little bit, we're all going to break that at some time. We go to a party and stay up till 2, but in general, wake up at the same time and it will help your sleep. Decrease or eliminate daytime naps, and particularly long naps. Naps up to 30-45 minutes don't seem to have much effect. Longer naps can be problematic. I mentioned alcohol. Eliminate or reduce your caffeine intake of any kind. And as I said, determine your cutoff time and realize it may be earlier than a few years ago. Get at least 30 minutes of moderate exercise daily, but not in the evening. You want to get that in the morning or afternoon, but not after dinner. And this is an important one. Get exposure to bright light in the morning and during the day, but again, not after dinner. If you can, dim the lights after dinner. Use the bed for only 2 things, sleep and sex. For some of us, that's maybe only one thing at times. And definitely not for reading or TV. Do not read in bed, do not watch TV, do not pass go. Stop watching screens of any kind for 30 to 60 minutes before bedtime. It's partly because the bright light, your phone has a setting for nighttime that makes it a warmer light. Blue light is thought to be especially bad for this purpose, for this problem, but it's really good to avoid screens altogether for half an hour before bedtime if you're having trouble sleeping. And if you go to sleep, go to bed and can't sleep, don't use bedtime as worry time. If you're not asleep in 30 minutes, or even less than that, if it's pretty clear to you you're not going to sleep, get up and listen to some soft music, read for a while, but not on a screen, and avoid bright light, and give it another try. Don't worry too much about your trouble sleeping. It's very, very rare that sleep deprivation kills anybody or makes anybody really sick in the short term. If you have a bad night occasionally, that's kind of part of being older for a lot of people. If you're preoccupied with something, try a simple repetitive mental exercise. Counting sheep is the It's a classic, but you can do little number extras. I used to have one, do 1A, 2B, 3C, 4D, and so on, and then do A1, B1. But I got so good at it, I could do it with, and still think about other things, so you have to change it up. At any rate, another thing you can do is relaxation exercises, slow, deep breathing, or purposefully relaxing muscle groups, either starting with your toes and working up, or starting with your eyes and working down. Pay particular attention to your jaw, because you have to go to the bathroom at night. Don't turn on bright lights. Use a flashlight or a night light, but don't try to do it in the dark either. Avoid heavy evening meals and bedtime snacks. Maintain a regular bedtime and a preset bedtime routine. No last-minute email checks or mini projects. That's a bad habit of mine. Control the nighttime environment. Darkness is especially important, but make sure everything else is comfortable. Use a sleep mask if you have a night out partner or other lights you can't control. Here's a simple sleep diary. I won't detail it. You can find one online, or I can print up some if anybody's interested. So what if you do need medical evaluation for a sleep disorder? How does that work? You can start with your primary care physician, or if you strongly suspect something like sleep apnea, you can go directly to a sleep specialist. And in any case, you may need a referral. Sleep specialists are usually neurologists or internists with special training in sleep medicine. Add a list of medications, of course, to the sleep diary before your first appointment. You'll have a regular history and physical questions to screen for some of the disorders we've mentioned. Because obstructive sleep apnea is so frequent and is medically so important, I need to say a good bit more about it. Despite its importance, it was only recognized and clearly described in the 1970s, when most of us were fairly long in life. William DeMint became something of a crusader for awareness of this situation. In healthy older adults living independent, obstructive sleep apnea occurs in more than 1 in 4 men and 1 in 5 women. In nursing home populations, the prevalence rises to about 1 in 3. Untreated sleep apnea is associated with a markedly increased risk for hypertension, stroke, as well as cognitive deterioration. So it's a very important issue. These are some numbers on risk factors. This cartoon tries to show where the problem is with obstructive sleep apnea. Normal breathing, we may snore a little bit, that's not abnormal, but we normally breathe in an unobstructed fashion. We have a curious anatomical feature. Our breathing tube and our eating tube start out in opposite positions and cross in our throat, in our oropharynx. And that causes problems because you have to have a traffic cop, a little valve called a glottis. During apnea, the person's respiratory efforts increase, but the glottis closes. Basically, you may have noticed that as we get older, certain parts of our anatomy sag. This is true of our oropharynx as well. So the mouth structure or the throat structure sag and block snoring or block breathing periodically. So that's what sleep apnea is all about. You may need a sleep study and you'll get recommendations for treatment. So with that, I think I've used my time and maybe a little more. So we'll see what the panel has to ask us.
Kathy. Bill, I have a question. This came to me from one of our residents. My spouse has gone to healthcare, and I don't know why I'm having such trouble sleeping. Could it be anxiety, lonesomeness, fear, all of the above?
Okay, thanks, Kathy. I think your friend has the right idea. Certainly life changes can prompt anxiety, worry about the spouse, being unused to being alone, sometimes even depression, although that's not automatically assumed. But all of these things can interfere with sleep, and usually are transient. If they persist very long, then maybe some medical evaluation is indicated.
Hi, I'm Jerry Smith, and Bill, on the same idea, some of us who are widows have trouble sleeping or staying asleep. And we're just not used to being in a bed by ourselves. Do we just need something to cuddle up to?
Well, that sounds like a good idea if you can figure out what that would be. Actually, I'm being a little light about that. I know of one personal acquaintance, a bit younger than we are though, who found that getting a big long pillow to cuddle with was helpful in that regard. So that's at least one thing to try.
Right.
Where do nightmares come into this equation of sleeping?
There are several sources of nightmares. Anxiety disorders, PTSD, of course, and also, ironically, things like alcohol. If you drink heavily, it'll put you to sleep, but it'll screw up your sleep architecture. That's not a technical term. It will compress your REM, it suppresses REM sleep, but interestingly, as it's compressed, you tend to have more vivid sleep, and often, after drinking heavily, you may have nightmares. But anxiety can cause nightmares. I'm not saying too much about the psychology of sleep and dreaming. Freud, though, thought that dreams were the protector of sleep. He didn't know about REM cycles, of course. And that a nightmare or an anxiety dream is the technical term, or the medical term. Anxiety dreams were when that failed and the anxiety broke through. There may be some truth to that as well. And I might say, for people who have awakening during the middle of the night at 3 to 4 o'clock, that's usually after the periods of deep sleep. You often don't go back to stage 4 and maybe not even to stage 3 after about that time. So that's a time when you may have awakening. Interesting, in some cultures, that's sort of expected, and people, I guess, get trained to wake up, and they'll wake up and do something and read and then go back to sleep, and that's culturally the expectation. It's something we may do to deal with the problem as well.
Bill, are there any over-the-counter medicines that you would advise one take or not take for having sleep problems?
The whole question of medication for sleep is an interesting one. I should issue a disclaimer. I do have an MD behind my name. I retired my license about 10 years ago, so I'm not a licensed physician, and even if I were, this is all for general information and not medical advice. With that disclaimer, if we were all 40 years younger, I would say, yeah, try a Benadryl, antihistamine that makes you drowsy. It's not a good idea for people our age. Why? It exhausts an enzyme called acetylcholine, which means we're likely to be groggy in the morning, and it's very well established that it will increase the incidence of falls and other accidents. And the longer you take it, it's a cumulative thing. I would really avoid medications for sleep, with the possible exception of melatonin. Melatonin is not a sedative. It's a substance that's secreted by the pineal gland normally. The hypothalamus sends it a message, and it starts in the late evening, and ends in the morning. It's not a sedative. It doesn't put you to sleep, but it sort of gives your circadian rhythm a boost in the direction of sleep, and many people find it helpful. I might mention sleeping pills in general. We've made such strides in treating all sorts of things with drugs in the last century. And you know, we all want a pill for it, that's the easiest way. But there are situations where brief temporary use of sedative drugs is helpful. It's almost never helpful long-term, and it causes more problems than it solves. There are a few drugs that are particularly problematic in this way. One is a benzodiazepine tranquilizer called Xanax. It's a very potent anti-anxiety drug, often used for panic disorder, and it's frequently prescribed for sleep. Unfortunately, if you've been on Xanax for any time at all, it's the very dickens to withdraw it, and it's worse than other benzos. There's a newer category of sleep medications called the Z drugs. Ambien is the best known, Sonata, and I'm forgetting the third one. They all have Z in the generic name. They're good in terms of putting you to sleep and keeping you asleep, but Ambien's the best known to have what are called complex sleep behaviors. You can go to sleep, and without ever realizing it or remembering it, get up, cook a meal, go drive to 7-Eleven. There have been scores of accidents and deaths. The Ambien went on the market, I believe, in the early 90s. It took until 2019 to get a black box warning. And they all have a black box warning now. Enough said.
Vicki, I think time for one more question, Kathy.
This has more to do with the comfort of one's sleep. You mentioned it earlier about temperature and physical comfort. But you know, there is so much, just like the medication levels, there are so many advertisements out there about this is the best bed to sleep on, this is the best mattress to get. Is there really any solid strength behind that, or is it just plain old flat mattress and let's go with the kid?
Different people, I'm not an orthopedist, but I've played around with what's a comfortable mattress, and the short answer is it's different for different people. A lot of the hype about sleep numbers and all of that I find a little overdone, but if it works, hey, I wouldn't, particularly for a couple who have different desires about. Partly depends on whether you're a back sleeper or a side sleeper. Definitely it can be a problem. If you wake up with a morning backache, it's probably a problem, or if you can't get comfortable. It's sort of a cut and fit sort of thing.
So that's it for tonight. Bringing this session to a close, I want to particularly thank Dr. Sluice and our two panelists, Kathy Kelly and Jerry Smith. And many thanks to our committee members who are working behind the scenes to help get things organized. Anne Marie Harrison, Ken and Carol Cook, Boyd Taylor, and our leader, Lori Humphreys. So with that, we'll close this program for tonight.